Oh, man. Hello, good morning.
Morning, sir. Morning.
Hey, how you doing, Vinod? Oh, that's Ike. That's Ike. Hold on. Hello, good morning. Hold on.
John, good morning.
Yeah, how you
Deepak.
doing, Ike?
Pretty good.
You have a rough night?
Yeah, we had a rough night. So we had this huge tumor. John, good morning.
Yeah, how you doing, Ike?
Hi.
Pretty good.
You have a rough night?
Yeah, we had a rough night. So we
Yeah,
had this
let
huge-
me turn off. Let me turn off. Your phone. Hey, Vinod, how you doing? Can you
pretty
hear me?
good, John.
Yeah.
Hey,
So-
Vinod,
So Vinod's filling in, huh?
Vinod is all ready?
Yeah, he's here.
Okay, great. So
Go to bed.
let him do the
Go to
yeah,
bed.
let him do let him do the endoscopic anatomy today. Let's enjoy this.
Okay.
Vinod.
Okay. Go to sleep.
I'll just watch for some time and then maybe I'll be off to sleep.
Okay. Okay, Vinod, about 5 minutes, okay?
Yeah, sure, John.
Ipe? I don't know if you Ipe either.
Yeah, tell me.
Yeah,
I'm
yeah,
here.
you know, I think Hera could help a lot if she got speakers for you and arrange the schedule, you know?
Yeah, so
John,
that's what we want to do.
She could.
Yeah,
It's tough.
we are getting Chandra, we are getting Roman, we are getting Narayan, Vinod, all these guys, stalwarts,
Right.
coming in.
Hello.
Yeah, we like to get them committed, like, okay? If Hera can get them committed to a day, you know?
Done.
Yeah,
This is going to be done.
Well, you know how it is. Like everybody says, "Oh yeah, I want to speak," but then it's hard to get them to come.
I know that. Yeah.
Yeah.
But we will start it, John, because these guys are free right now.
Good. Let's get them now.
John, can you hear me now?
Yeah, we can hear you.
Hello.
Yeah, we can
John?
hear you.
Yeah, we can hear you.
Hey, John. Hi.
Yeah, how you doing?
I'm ready. Yeah. Hi, sir.
Yeah.
Well, you know, I sent a post to ENT today. ENT, you know, that online. I don't know, like a lot of people belong there. I think is ENT surgeon, no ENT today. But we're gonna show Vinod how we're making this a complete experience. Now, Vinod, do you have Facebook Live? Do you know how to do a Facebook Live, Vinod?
Yeah. Okay.
Okay, do it now from your smartphone. Get on your smartphone, start the Facebook Live, and say, "Hey, I'm Vinod. This is Vinod. I'm doing a webcast at Neurosurgical TV. Come on and watch me." It's like a promo. It's like a TV promo.
Okay, but I have never used the Facebook Live.
Yeah, you just put Facebook. I know, but let's try it. Let's learn it. Just start a Facebook Live now and say, "Hi, this is Vinod, Felix. I'm going to present endoscopic anatomy." That goes to all your followers. You know what I mean? Just push the and you too, Ipe, if you want to do it quick.
Yeah, I can do it now. I could do it.
Yeah, do it to your followers.
Yeah,
is speaking.
I'm going to do it right now.
You good? If we can get everybody to do that in the panel, do a quick Facebook Live. All of you guys, we're going to put you panelists to work. You think you're going to go and just sit here?
John, I'm live right now. So today we are doing the fourth daily dosage for neurosurgical anatomy, neurosurgical TV with neurosurgery coach. So today Vinod Felix will be doing endoscopic anatomy. So of course, skull base and skull base is part of the endoscopic. Endoscopic skull base is part of the skull base. Pardon me, I'm a bit jaded because I was up all night yesterday. So that's precisely why I'm not doing it. And the guys who should be doing it, they are doing it today. So big hoorah to Vinod to be taking it up at a very small short notice. So Vinod, go ahead. Neurosurgical TV, go ahead. Let's start and do this endoscopic anatomy.
Okay.
Very, very good. Okay. Let me start this one. Let me start this. Okay. 10, 9, 8, 7, 6. Hi, this is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the pleasure of having Vinod Felix, an old presenter from here. He's not old, but I mean, he's been doing this for a while. He's going to present on endoscopic anatomy. Before we turn it over to Vinod, let's see if we can meet some of the panelists. Let's see, Deepak, are you here? Deepak Singh, Roberto Basati, Augusto, could you please present yourself? Or perhaps Waleed Abbas, are you there?
Yes, sir, I'm here.
Yeah, hi, could you say hello?
Hello, sir.
Hello, hi. How are things there? How are you?
Perhaps Waleed Abbas, are you there? He's calling from Sudan.
Yes, sir,
Okay.
Could you say hello?
Hi, Deepak.
Oh, hi. Okay, very good.
How are you?
Hi, Khalif. Are you here? Are you here, Khalif?
Okay.
From Sudan.
Hello, Deepak. Good to see you.
Deepak Bengal.
Hi.
Okay, very good. Okay. Are you here? Okay, Vinod, it's a little confusing here. Why don't you start your presentation and welcome. Thank you. Okay, Vinod,
So,
why don't you start, okay?
Okay. So it's a pleasure to meet you all.
Presentation and welcome. Thank you. I'm just turning off some of the sound here. Please mute yourself if you're not talking. Okay, there we go. Okay, Vinod, I think we got that clear thing. Did I mute you? I muted you. Okay, Vinod.
Okay. Yeah.
Yeah, there we go. Okay, we're all set.
Just a minute.
Okay.
So it's a pleasure to meet you all and on a Sunday. And I think you're all still energetic in spite of all this COVID things going all around. So my presentation would be a very basic presentation on endoscopic anatomy of nose and paranasal sinus for the neurosurgeons.
Okay, you're not quite sharing yet.
Are you getting me now?
Not yet, not sharing yet. You're starting it, but. Once you pick the screen, you have to click share.
Yeah, I am getting, but actually I'm getting this screen here.
Oh, okay, yeah, we're just getting a blank screen here. But take your time, we'll get it. This is new tech for a lot of people. So maybe start it again.
Okay.
Get off the screen share and come back. Okay, once you get off the screen share, Vinod, and we'll edit all this out. There we go. Okay, now start it again. Start it again. There you go. Now pick the screen. There you go. There you go. We got it.
Got it? Okay, yeah. So this is a very basic talk on endoscopic anatomy of nose and paranasal sinus. It's basically for the neurosurgeons. It's not for an ENT crowd. So just a minute. Actually, when you take the nose and paranasal sinuses, the nose has a middle nasal wall, middle part that is nasal septum and the lateral nasal wall. So the nose and paranasal sinuses, they are the corridors or the cavities through which you approach the skull base when you do the endoscopic skull base surgery. So you have to know the corridors very well, because anatomy is destiny. Without knowing anatomy, you cannot be doing this endoscopic skull base or any surgery. If you approach the skull base without knowing your anatomy, this is what will happen. Okay, so anatomy is destiny. Without knowing anatomy of the nose and paranasal sinus, it's practically impossible to do an endoscopic skull base surgery. So the nose, as I told, has a lateral nasal wall and the septum. The lateral wall has 3 turbinates. So this here is the nasal septum. This is the inferior turbinate, middle turbinate, the right side. It's the inferior turbinate on the right side, nasal septum, middle turbinate. Once you lateralize the middle turbinate, this is you see the superior turbinate. This is superior turbinate. This is the septum, and in this space, rarely you can have a supreme turbinate like this. This is a supreme turbinate, but this is very rare. Usually, when you lateralize the superior turbinate, you come to see the sphenoid ostium. So you have the 3 turbinates: inferior, middle, and superior. And between the superior turbinate and the nasal septum, we search for the sphenoid ostium. I have seen instances where the operating surgeon used to search for the sphenoid ostium for about 3-4 hours, because without identifying the sphenoid ostium, you can never open the sphenoid sinus and never do a pituitary surgery. So identifying the sphenoid ostium is a very essential step in endoscopic pituitary surgery. And another very important thing is that turbinates, they always point towards the clivus. For example, the inferior turbinate points towards the inferior clivus, middle turbinate towards the mid clivus, and the superior turbinate points towards the superior clivus. So that is another important thing about the turbinates. And as I told you earlier, the superior turbinate is a very important landmark to identify the sphenoid ostium. The sphenoid ostium, it corresponds to the inferior aspect of the superior turbinate. The inferior half of superior turbinate is almost at level with the sphenoid ostium. And if you don't find the sphenoid ostium, you can just measure about 12 to 15 millimeters from the roof of the nasopharynx, or the roof of the choana, and that will take you to the sphenoid ostium. So these are the important landmarks or important ways how you identify the sphenoid ostium when you do the endoscopic surgery. So this again is the right side. That's the middle turbinates being lateralized. Now you are seeing the superior turbinate. And as I told you, you search for the sphenoid ostium between the superior turbinate and the nasal septum. It almost corresponds to the inferior half of the superior turbinate. This is the sphenoid ostium. This is the superior turbinate. This is the inferior half of the superior turbinate. And you can see the sphenoid ostium there. And another important thing for identifying the midline when you're operating on the pituitary is this rostrum of sphenoid. The rostrum of sphenoid is also a very important landmark. And this is the sphenoid bone. This is sphenoid rostrum, the sphenoid ostium. The sphenoid rostrum is almost always, it's always in the midline. So once you are lost, you look for the sphenoid rostrum. The rostrum will tell you about the midline. So this is the sphenoid sinus widely opened, and this is the sphenoid rostrum. So this rostrum will be always in the midline. The rostrum in this image will be here, and this will be the midline. So once you are lost during your endoscopic pituitary surgery, the sphenoid rostrum is a very important landmark. It tells you where the midline is. And coming to the paranasal sinuses. So I just now went through the corridor, the nasal cavity, and we must also know about the paranasal sinuses. As you know, there are the paranasal sinuses, the paired paranasal sinuses are maxillary, frontal, sphenoid, and ethmoid sinuses. These sinuses are named after the corresponding bone which contains the sinus. And of all these sinuses, the most important is the sphenoid sinus, because sphenoid sinus is I think I can get this background noise tone. I think somebody is unmuted. Okay. Anyway, the sphenoid sinus is the most important thing in the endoscopic skull base anatomy. So this is the entire sphenoid sinus exposed. The anterior wall of sphenoid sinus was here. The sphenoid sinus is open, and inside the sphenoid sinus, these are the important structures. This is the cellar floor. This is the cellar floor inside the sphenoid sinus. This is the intersphenoid septum. The intersphenoid septum, in almost 70 to 90% cases, it takes you to one or the other carotid artery. And that is why we say we must never pull on the intersphenoid septum. The intersphenoid septum, and this is the clival recess of the sphenoid sinus. And these are the important structures, the optic nerve. The left optic nerve is the right optic nerve, is the right carotid artery, left carotid artery. This actually is the paraclinodal portion of carotid artery. That's what is seen here in the sphenoid sinus. So the recess between the optic nerve and the carotid artery here, this is known as the lateral opticocarotid recess. And this actually is a pneumatization of the bone called the optic strut. You have the optic strut here, and pneumatization in the optic strut forms the lateral opticocarotid recess. And this recess here, this is known as the medial opticocarotid recess. These are very important landmarks when you do the endoscopic pituitary surgery, because we must remove the bone over the medial opticocarotid recess when you go for the pituitary tumor of the suprasellar extension, because this bone here forms a bottleneck in removal of tumor in the suprasellar region. Once you remove this bone, the tumor descends easily, and we can remove the tumor with much more ease. And what is also important is the type of pneumatization of sphenoid sinus. We have the three types of pneumatization. We have the congal, the precellar, and the cellar type of pneumatizations. This is the congal, the precellar, and cellar pneumatization. Because in some cases, the pneumatization of sphenoid is very much rudimentary, like this, called the congal pneumatization, as in here. So this you just have this airspace, and in such cases, it is very difficult to do the surgery without having the aid of the neuronavigation. And so sphenoid sinus is a surgical corridor to approach the sella turstica here. It's the sella, the clivus, and this is the planum. So the suprasellar region, the cellar region, and the clivus, and the parasellar region can be approached through the sphenoid sinus. And coming to the frontal and ethmoid sinus. The frontal and ethmoid sinus, this is a frontal sinus, and these are ethmoid sinus. Once you open the frontal sinus and remove all the ethmoid sinus, as demonstrated in this image, you reach the cribriform plate. So this is the nasal septum removed, This is the right side, this is the left side. We have removed the nasal septum, we have removed the middle turbinate, and we have removed all the ethmoid cells, and we have opened the frontal sinus. And now you are seeing the cribriform plate on both sides. It's a cribriform plate. The cribriform plate, this is the fovea ethmodalis, and this approach is called the trans-cribriform approach. And once you do that, you can remove a tumor which is lying in the cribriform plate region, like a cribriform plate, olfactory meningioma, or an esthesioneuroblastoma. All these tumors which lie in the cribriform plate region can be removed by doing this approach. And the very important landmarks here are the anterior and the posterior ethmoid arteries. This is the anterior ethmoid artery. This is the posterior ethmoid artery. I'll just show you a surgical example. So this actually is a esthesioneuroblast of the left side. With the left nasal cavity. We already removed ethmoid cells. This is the left side. This is the orbital wall. This is the frontal sinus. And this is the anterior ethmoid artery. This is the anterior ethmoid artery. There is a tumor being peeled off from the skull base. And now the anterior ethmoid artery is cauterized. Do the same thing for the posterior ethmoid artery. And when the cribriform plate is drilled open, that's a dura. And
we are not able to see the video, just a picture, John. I mean, just a picture, Vinod.
Okay.
Vinod, do you want to see a video here? Or?
Yeah.
Okay, it's not working correctly, right?
Maybe I should minimize the screen and then go back.
Yeah, we try to restart it.
What about
now?
Are you getting it now?
You know what we can do? Just get off the screen share and come back in. Because you got to mark that to put audio on your video.
Okay.
Okay. So like another, before you start to share, it has two little boxes at the bottom that says share audio. So start the screen share again.
Okay. Are you getting the video now?
I can't hear it now. Is it necessary to hear it?
Are you getting the video now?
Yeah.
Yes, we are seeing it.
Yeah. Why don't you just comment? Why don't you just comment instead of having the recording play? Okay.
Okay. So this is the left side. It's actually an esthesioneuroblastoma, which is involving the left cribriform plate. There's a left frontal sinus. There's the left frontal sinus, and this is the left anterior ethmoid artery. That is the left orbit, medial orbital wall. The periorbit is exposed here. We are removing the tumor from the skull base now. That is a tumor. This entire thing is a tumor. We are peeling the tumor from the skull base. And this is the anterior ethmoid artery. We'll be cauterizing the anterior and the posterior ethmoid arteries. We'll be cutting the arteries then. So that is the anterior ethmoid artery being cauterized. And after cauterizing the ethmoid arteries and cutting the arteries, we'll be drilling open the cribriform plate. There is a cribriform plate and the fovea ethmodalis, the ethmoid roof being removed. And that's a dura. That's a dura being exposed. Those are the olfactory filaments. See, this actually is the frontal lobe. You're seeing the frontal lobe now. It's a frontal lobe, and this is the olfactory bulb being cut so that we get a tumor clearance. And this is done under frozen section control. And now that's a reconstruction with fat and facial data. So we approach this area by going through the ethmoid and the frontal sinus. Are you getting this screen now?
We are seeing you. We are not seeing the screen share.
There we go. There we go.
Okay, yeah. So by going through the sphenoid corridor, we can approach the cella turcica, supracellular region, clivus, the paracellular region. By going through the ethmoid and frontal sinus, we can approach the cribriform plate, the frontal lobe, and all these regions. And we actually have a classification which has two modules. This is the classification, and it has a sagittal plane and a coronal plane classification. So in the sagittal plane is a plane which lies between the plane of two medial orbital wall. So between the plane of the two medial orbital wall, from anterior to posterior, we can approach different modules. This is a transfrontal approach to approach some pathology in this region. This is a transcribiform approach. You saw the example in the previous video. And this is the transplanum approach for supracellular lesions, and transcellular approach for the pituitary tumors, transclival approach for the clival chordomas, and this is the transodontoid approach. These are the approaches in the sagittal plane. So the 1, 2, they use the frontal and ethmoid sinus. 3, 4, 5 use the sphenoid sinus. And the coronal plane dissection is a plane which is the dissection lateral to the plane of the medial orbital wall, or lateral to the plane of the internal carotid artery. And here we use the maxillary sinus, because if you come through this nasal corridor and sphenoid sinus, you won't be able to reach the lateral aspect. So if you need to go laterally, you need to open the maxillary sinus. This is a schematic diagram showing that you can open the maxillary sinus and go through the maxillary sinus. This is the pterygopalatine fossa, and by doing that, we can reach far laterally into the coronal plane, to the Meckel's cave, to the we call this suprapetrous, intrapetrous approach. All these approaches needs the maxillary sinus as the corridor. So coming to the maxillary sinus, these are the maxillary sinus on both sides. So once you open the maxillary sinus and you remove the posterior wall of maxillary sinus, you reach what is called the pterygopalatine fossa. The pterygopalatine fossa has a maxillary artery which divides into the sphenopalatine artery and the descending palatine artery. And behind the artery, you have the maxillary nerve. This actually is the intraorbital nerve coming and running as the maxillary nerve into the foramen rotentum. This is the foramen rotentum, and this is the pterygopalatine ganglion. This is the Vidian nerve. So all these structures lie in the pterygopalatine fossa. So once you open the maxillary sinus, remove the posterior wall of maxillary sinus, and you cauterize these vessels, and you lateralize the pterygopalan fossa, you can reach this region, which is called pterygoid base. The pterygoid base, and this is the foramen rotentum. This is the Vidian canal. Once you remove that bone, you can approach this region, because by going through the sphenoid sinus without opening the maxillary sinus, you won't be able to approach this region. So this is the coronal plane dissection. This coronal plane dissection needs to open the maxillary sinus. And these are the areas which we can approach by doing the coronal plane dissection. We can go to the Meckel's cave. We can approach the uterus apex. I'll just show an example of this also. So this actually is a petroclival chondrosarcoma.
Но, наверное, кого-то смотрит из пациентов.
Oh,
Ну,
sorry.
здесь
Okay. I'll come again.
Вы с больничным, сейчас он
I'm
подойдет.
sorry, I'm
Простите.
sorry. Let me try to get that. Okay. Okay, sorry about that.
Are you getting the video now?
Yes.
So this actually is the petroclival chondrosarcoma. This is the right nasal cavity. Sorry, this is the left nasal cavity. We are taking the Haddad flap on the left side. And now this is the right side. This is the inferior turbinate. It's the septum. This is the right inferior turbinate. We are removing the right inferior turbinate. That's the right inferior turbinate being removed. This actually is the middle turbinate. And now we are opening into the maxillary sinus. This is the maxillary sinus being opened, because to approach the paracellular region, we need to go into the maxillary. We have to use the maxillary sinus corridor in addition to the nasal cavity and the sphenoid sinus. So this is the nasal cavity. We'll be opening in the nasal cavity, sphenoid sinus, and in addition to that, we'll be using the maxillary sinus also as a corridor. This is the anterior wall of the maxillary sinus being exposed. That's the anterior wall of maxillary sinus. Now we are drilling open the maxillary sinus. That is the maxillary sinus anterior wall being opened. That is the maxillary sinus. And that is the posterior wall of maxillary sinus has been removed. You are seeing the pterygopalatine fossa there. That's the pterygopalatine fossa, which is seen after removing the posterior wall of maxillary sinus. That is the posterior wall of maxillary sinus. And this is the pterygopalatine fossa. That is the pterygopalatine fossa being lateralized to identify the Vidian nerve and the foramen rotentum. The Vidian nerve is also a very important landmark in endoscopic skull-base surgery, because once you trace the Vidian nerve, it takes you to the foramen lacerum. So it helps you to identify the foramen lacerum. So this here is the Vidian canal. This is the Vidian canal. Now this is the sphenoid sinus widely opened. Now you drill all around the Vidian canal. This is the Vidian canal. You drill all around the Vidian canal, and that takes you to the foramen lacerum. And you also get, once you remove this bone, you get a much more wider cavity to operate upon. You're already seeing the paraclaval carotid artery and the foramen lacerum is being identified by drilling around the median canal. There is a carotid artery, foramen lacerum, paraclaval, horizontal, and the petrous carotid artery. It's a petrous carotid artery. Now we are drilling the clivus. It's the clivus. It's actually the petroclival synchondrosis being drilled. And once you do that, we are right now at the petrous apex. The petrous apex approach through the sphenoid sinus and the maxillary sinus. So the main purpose of this presentation is to get you oriented about the paranasal sinuses, the relationship of the sphenoid sinus with the sella, suprasellar region, clivus, parasellar region, and the relationship of ethmoid sinus and frontal sinus with the cribriform plate, and the relationship of the maxillary sinus with the, and what is the purpose of opening the maxillary sinus to approach the parasellar region or the coronal plane dissection. So I hope this presentation gave you a rough idea about the anatomy of the nose and paranasal sinus and its relationship with the skull base. So,
Vinod, could you show schematically as to when you approach the petrous apex? I mean, you are approaching it from the maxillary sinus. So in the maxillary sinus, your first landmarks obviously is your descending palatine, sphenopalatine artery, your maxillary artery, your median nerve, your V2 going to the foramen rotundum. And from there, you need to show the carotid, and you need to show as to which side of the carotid are you approaching the petrous. You know, you can approach it from both sides actually.
Okay, I understand.
You could approach the petrous apex from the cavernous sinus side also, I mean medial to the carotid as well, and lateral to the carotid as well. So you would, I mean, I would like you to probably, you know, these are the things that you might want to make clear for the young guys. So how are you approaching? And, you know, what are the problems that, you know, you will face when you have to, supposing you have to displace the carotid medially or laterally, what are the structures that you would need to cut? Say, for example, the petrolingual ligament, where would it be?
Okay. So actually you can go with this diagram. This actually is the carotid artery. It's a paraclaval carotid artery. It's the horizontal petrous carotid artery. This is the median nerve. In the previous surgery, we were operating on the other side, the right side. We are drilling this bone here. But before that, I think maybe I'll switch over to another presentation. I have a presentation on the coronal plane. I think the slides you are asking are not in this presentation.
No, what you did was perfectly right. What you showed, that picture was perfectly right. It was beautiful. So basically, you drilling so you have C3 carotid there. C3, yeah. You show the C3 carotid. That is C4 carotid. C4
C1,
carotid.
C2,
No. Yeah, C3 carotid, parasellar carotid.
Parasellar, okay.
Yeah, parasellar carotid, C3 carotid. C5 is paraclaval.
This is paraclaval.
Yes. So you are going medial to paraclaval carotid, right?
Yeah.
You are going medial to paraclaval carotid.
We are drilling this bone, the petroclaval synchondrosis.
Yes, absolutely.
We identified the median nerve. We drilled around the median nerve. We identified this portion of carotid artery. We identified. We drilled the carotid from here to here.
Yeah.
This much carotid was exposed.
Excellent. In other words, what we are trying to say is if you drill the clivus quite laterally, it is going to take you to the petroclival synchondrosis.
Exactly, yeah.
Yeah, so we are going from a medial to lateral approach. But would you like to say something about going lateral to cavernous sinus and then mobilizing the carotid medially and then reaching the petrous apex also?
Exactly. So if you need to mobilize a bit more, we can drill the bone here, and you
That is
can and you have the petrolingual ligament here. The petrolingual ligament is exactly here. You drill the petrolingual ligament, drill all this bone, and drill this bone. Now we can lateralize the entire carotid artery, and you get much more space to approach the petrous apex.
Absolutely, absolutely. This is what I wanted to make it clear. Excellent, beautiful presentation. Beautiful presentation.
Thank you, sir.
Yeah, no.
So, John, is there any doubts from the audience?
Oh, okay, very good. Very good, Vinod. Thank you very much.
Thanks, John.
Thank you very much. Okay, especially at the last minute coming in here. And are you in Nepal now? Are you in or in Kerala?
I'm in Kerala. Yeah.
Oh, okay.
We are also on lockdown.
Oh, yeah. Okay. Okay. Any comments or questions from the panel?
Yeah, I would like to just show on Vinod's this slide. This slide is a beautiful slide. So on this slide, I would like to show the vertical segments of the carotid actually. So you can see the C3. I mean, you can see the optic nerve. Maybe Vinod can point to the optic nerve. Yes. And then you can see the carotid, that is a C3 carotid there. Yes, the paracella carotid. And you can even see the C4 carotid there. And then you can see the other vertical, that is the paraclival carotid. So you can see the paraclival carotid. You see, that is the paraclival carotid. That is C5. So C3, C5. You can see the petrous carotid there also. Somebody is obviously done a sublaceral drilling and exposed the petrous carotid. I remember Vinod coming to my center and helping me do this dissection maybe 3 years back. So that is sublaceral drilling and the paraclival carotid. And then you can even see the parapharyngeal carotid, you know, it's beautiful, parapharyngeal carotid, C7. So behind that, you will obviously find the cochlea, okay? So this is a very, very wide coronal exposure. So you can see C3, C5, and C7. And as Vinod obviously said, the approaches to the petrous apex, I mean, obviously neurosurgeons very rarely approach the petrous apex in this way. But then if you want a good exposure, it is an excellent exposure going lateral and medial to the paraclival carotid. Thank you.
Okay. Very good. More comments and questions from the panel? Khalif, are you there? I'm always
Yeah, I can. Yeah, I'm following John.
Okay, how you doing today?
Excellent.
Okay.
Been a lockdown, and I enjoyed the excellent presentation.
Okay, very good, Khalif. Welcome.
Yeah.
Any more comments from anybody? Okay, I guess it's pretty straightforward. You can get off the screen share now if you want, Vinod. Okay, very good. Very good, Vinod. So how are things going in Kerala? This is your day off, right?
Yeah, we are on house arrest.
Yeah. Now, are you going to the hospital now, or just for emergency surgery?
Actually, I stopped doing all the ENT surgeries because the nasal cavity has a maximal viral load. So as per recommendations, all nasal procedures should be avoided unless it's an emergency. Unless the patient is going to die within 24 hours, it's better not to do any surgery to the nose in this COVID time.
That's important to hear. Wow, that's very important to hear. I didn't know that. I think a lot of people don't know that.
Yeah. So no pituitary, no clival surgeries unless emergency.
Oh, okay. Okay. Well, what type of surgeries are emergencies in that part of the skull, in that part of the brain? Which types of surgery would be considered an emergency where you have to go in?
I didn't get that, John. What is that?
Which types of surgery would be an emergency that you would have to go in, irregardless of the status?
Suppose you have a pituitary tumor with, what you call impending loss of vision, or an
Okay.
apoplexy,
Okay.
or maybe something like that, which really threatens the vision or the life. That would be an emergency. But
Right.
all other situations, and even on those scenarios, we would like to go transcranially, because this COVID is really a high risk, because the nasal cavity has the maximal viral load. And when you are using the drills and the debriders, these are powered instruments. The virus is thrown into the air with high pressure. So even the N95 mask won't protect you in that scenario.
Okay. Yeah. Okay. Very good. Okay. More comments. Let's hear from the panel. How are things in your part of the world? Deepak, Bengali. How are things in your part of the world, Deepak? Or anyone that wants to volunteer. Augusto, Musindo, we talked to you the other day about Mozambique, and it was not on lockdown. Are you there, Musindo? Perhaps not.
Yeah, hi, John.
Okay, hey, how you doing, Waleed?
Yeah,
How
hi.
is it? What part of the world do you in, Waleed?
We are here in Egypt, like we postpone all kind of elective surgery now,
Okay,
and we are doing like urgent surgeries now, and we have
right.
like a curfew now, like 12 hours per day, and
Oh, okay.
all shops are closed and everything here. So only urgent surgeries, only an emergency.
Are you having to see patients, regular patients, as a doctor, or just
Yeah,
no?
yeah, but with more restrictions, and I think the more coming days there will be more restriction, and only will be the emergency of the hospitals only. I think so.
Yeah, it's not in the Miami. It's not that. I think the doctors can go where they want, but it's heading that way.
Yeah, we can
to
go
be
now.
like that.
Like, in spite of the curfew, we can move as the doctors, but still we only do urgent surgeries only.
Yeah, it seems in China they're moving around a lot more than before. Anybody else have reports from their part of the world? Roberto Basati, how you doing, Roberto? I know you're a student, and as a student, you always feel dumb. I know I did. Eminata, you want to say something, or anybody else want to tell us about what's going on in your part of the world? Perhaps not. But anyways, okay, very good. Vinod, thanks a lot for coming out, and now I'm going to end this session, and we'll see you guys tomorrow. Thank you. I'm going to close this. Oh, man. Okay.